Namaste and greetings from the World Health Organization. My name is Chandra-Mouli and I lead the work on adolescent sexual and reproductive health and rights in WHO's Department of Sexual and Reproductive Health and Research. In this brief presentation, I'm going to give you a global overview on violence against girls and young women, prevention, support, and care. This slide contains 4 definitions. I'm not going to read the text on the slide. I will leave that to you. Suffice to say that there are 4 terms described here: gender-based violence, GBV, an umbrella term for a harmful act that is perpetrated against a person's will and is based on socially ascribed gender differences between males and females. It includes a number of actions listed in this slide. The other 3 terms are violence against women, and in this case against young women and girls, intimate partner violence, and sexual violence. This is one of 2 slides which sets out the rationale for investment in and attention to this area. Again, I'm not going to read out all the text on the slide. The 2 points that this slide makes are: 1, that gender-based violence against adolescents is an important problem in terms of its scope. The numbers are provided on the slide, and it also makes the point that while the particular focus here is on young women and girls, sexual abuse also affects boys, and although to a lesser extent than girls. The second point is that gender-based violence against adolescents has major health and social consequences, as listed in this slide. This is the second of 2 slides which addresses the rationale for investment in and attention to prevention, care, and support for gender-based violence in adolescent girls and young women. The first point is that research studies and pilot projects have shown that such efforts can be effective. And the second point is, although laws and policies, prevention strategies, and their implementation are in place, they need much more attention. We moved from the needs issues to the rights issues. And this slide makes the point that states are obliged to prevent and address violence against women and girls, and to take all steps that they can to eliminate it. As we move forward, I'd like to share 3 points to consider. Firstly, even where gender-based violence prevention and care services are being implemented, they're being done at small in scale and piecemeal and not very well. What this means is that while we have the evidence, it's not being applied at scale and with quality. Secondly, many health workers are uncomfortable in dealing with gender-based violence and do not have the competencies and the support to do so. This is particularly when we talk about sexual abuse, which adds another layer of complexity. And thirdly, even where projects to address gender-based violence exist, adolescents do not seek them. They do not seek care, and that needs to be addressed as well. WHO has published a number of guidelines on preventing and responding to gender-based violence. The majority of them are not adolescent specific, but they are relevant to adolescents. There are some which are of which are particularly focused towards adolescents. For instance, the first item on the list. This slide lists a number of documents that are complementary to WHO's guidelines. They primarily include documents by WHO, but they also include some documents by other organizations. All these materials are available from the Geneva Foundation for Medical Education and Research and are available free of charge for use. This is one of 2 slides on specific measures to be taken in the context of COVID-19 to prevent gender-based violence and to respond to it when it occurs. These are taken from the document Not on Pause, responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis, co-produced by UNFPA and WHO in 2020. It lists a number of actions, and I'm not going to read them out point by point, but they're about informing adolescents about where to get care, making sure that both the health workers and the system are responsive to them, and trying to find shelters and sources of support outside the health sector too. As the world is slowly limping back to some semblance of normality, as the COVID-19 pandemic begins to end, certainly more in some parts of the world than in others, we need to start thinking about how we can make sure that the lessons learned in terms of both vulnerabilities and in terms of responses can be institutionalized for the future. And that's what this slide addresses. This slide provides a list of references. So this complements the list of guidelines and complementary documents. It also provides you with a source of documents that this module is based on, as well as points to follow up on if you're interested to do so. This cartoon is the last slide in my segment of the presentation. It's self-explanatory, but the key message here is a woman in distress who has experienced violence, and the wise message from the senior health worker is, let's care for her with what we can, and then discuss what she wants to do, and so that she can be a part of the solution moving forward. So with that, I come to the end of this segment of the presentation. Once again, namaste and greetings. I pass on the baton now to my regional colleague, who will give you a more in-depth regional perspective on this subject.
Welcome everybody to Model 7 on violence against women and girls, prevention, support and care. I want to express my thanks and gratitude to HQ colleagues. Thank you for sharing the global data and information. My name is Untitled Ronzoni, and I am the Gender-Based Violence Technical Officer at the WHO Regional Office for the Eastern Mediterranean from the Department of Healthcare Population, Violence and Injury Prevention and Disability Unit. And I will accompany you in this session on the Eastern Mediterranean regional perspective on violence against women and girls in terms of prevention, support, and care. Let's start this session with some key facts about violence against women and girls in our region, and particularly the data about the prevalence. From the recently published WHO Violence Against Women Prevalence Estimate 2018, we see that the Eastern Mediterranean region has the third highest prevalence on violence against women globally, with an estimated 31% of ever partner women who have experienced physical and or sexual intimate partner violence at some point in their lives. Adolescent girls, young women, women belonging to ethnic and other minorities, and women with disabilities face a higher risk of different forms of violence. In the below image, which reflect the available intimate partner violence prevalent estimates at the country level, we see that we have the highest prevalence in Afghanistan with 46%, followed by other countries. which are only a part of the 22 member states in our region. We, of course, have data from other countries in the region. However, these data were not reflected into the estimates, which only consider national official surveys produced before 2018. In fact, as you can see from the notes, survey data are available now for Saudi Arabia and Somalia, but these data were collected after 2018, so are not reflected in the current estimates. In this slide, we see data from demographic health surveys in Afghanistan, Egypt, and Jordan about experience of physical or sexual violence among adolescent girls. And there is a comparison of physical violence in the past 12 months for women 15-49 of age, as well as for girls between 15 and 19. On the right side, you see that the blue stands for the women 15-49, while the orange is for the girls 15-19. And in Afghanistan, there is a higher prevalence of physical violence against women above 15 years old, while in Egypt and Jordan, there is a slightly higher prevalence of physical violence against adolescent girls. The same is for experienced sexual violence, same trend for Afghanistan. Women above 15 years old are more prone to be subjected to sexual violence, while for Egypt and Jordan, adolescent girls are at higher risk of sexual violence, while for Jordan it is a 50-50. Looking at the physical or sexual, emotional violence committed by husband and partner, we notice that while adolescents are less likely to experience spousal violence in the three countries for which data is presented, they are consistently less likely to seek help or tell someone about the violence they are experiencing. The data on the right side about seeking help really tells us about the enormous barrier that women, and particularly adolescents and young women, face to seek for help and disclose the violence they are living within their household. These barriers start from the policy situation. As we can see from the slide, the Eastern Mediterranean region has the lowest proportion of country, 53%, with national multi-sectoral plans of action for violence against women globally. However, of the 16 countries that respond to the RMNSCH policy survey in the region, 81% cited adolescents as a specific group for defined intervention for gender-based violence. Likewise, 88% have a law to punish perpetrators of coercive sex involving adolescent girls. Now, while policies may be in place on the paper, the implementation of these policies may be very difficult and experiencing a lot of barrier that then can reflect in the possibility of women and girls to seek help and disclose the violence they are living. Some of these barriers are reflected also in the regional challenges identified. Among them, the high rates of child and forced marriage. Women and girls who are married as children are more likely to experience gender-based violence, not only in the region, but at the global level. Therefore, there is a need to strengthen the work with the additional institution, community, religious leaders, families, and government actors to systematically address this issue. We know that policies are not enough if these policies are not accepted and embedded into the society values. Underreporting is a big barrier. Due to social stigma, women and girls hesitate to report incidents and believe that nothing could be done. They are afraid of retaliation and further violence from perpetrators, and do not trust services due to fear of confidentiality breach or simply they are not aware about existing services that could support them to get out of violence. Attitude and social and cultural norms that are blaming the women for the violence they experience because she was out alone after dark, she was not modestly dressed, she's working outside home, along with gender discrimination and stigma, prioritize protecting family honor and social security over the safety and well-being of the survivors, and encourage institutional and social acceptance of GBV as normal, as well as ensure impunity for perpetrators. When we talk about attitudes toward gender-based violence with a consequent difficulty for survivors to disclose the violence they are living and seek for support, these slides show us the proportion of male, 15-49 years old, who consider her husband to be justified in hitting or beating his wife, but also proportion of female, 15-49 years, who consider a husband justified in hitting or beating his wife. As we see, the prevalence is very high. We have 70% among male in Afghanistan, 78% of women in Afghanistan. In Jordan, 64% of men against 63% of women. Pakistan, 58 for men, 51 for women, and so on, as you may see in this slide. This means that it is a culture embedded not only in male members of the society, but also in female members of the society. And so this means that violence is normalized and therefore it is not recognized. Many women do not disclose violence because they don't have the possibility to do so in terms of lack of health services or other services, but also because they are not aware that what they are living is actually violence or an expression of gender-based violence. We saw cultural barriers, but there are also structural barriers, such as lack of information, low availability of services, and numerous humanitarian settings. In terms of lack of information, there is a limited information available to the public regarding consequences of gender-based violence. If we think about child marriage, few people maybe know about the severe health consequences of child marriage, and the consequences of violence at the mental health level, and the availability of potential legal, social, and health support services for the survivors. When this information are available, we may also face low availability of services. Women and girls who experience gender-based violence are likely to seek family planning or maternal health services. Therefore, the health sector is one of the key entry points for ensuring survivors get the care and support they need. We saw this very well in the during the COVID-19 pandemic, which we will address in this session as well. Many other services were locked or closed because of the lockdown, and so the only available services for women who were living under the pandemic and under the gender-based violence could seek help only through health services. Unfortunately, these services are often not available. For example, a recent survey showed that only 10% of facilities in Afghanistan are well prepared to address gender-based violence, and that only a quarter of the 280 health facilities surveyed in the 7 provinces had a private examination rooms, and only 2% of facilities had a protocol in place for GBV care, which means that the minimum standard for providing safe, confidential health care to GBV survivors, it is not possible because the health structure are lacking the minimum requirements. Numerous humanitarian settings are also among the challenges that characterize this region. And we know that our region is one of the regions with the highest prevalence of humanitarian settings. 1 in 5 refugees or displaced women in complex humanitarian settings has experienced sexual violence. So when we have humanitarian but also health emergencies, we know that the risk of GBV dramatically increase. Meanwhile, care services for women and girl survivors of violence remain one of the least implemented parts of the minimal initial service package. So it's very important that humanitarian workers as health providers, we advocate to include GBV services among the list of essential life-saving services during humanitarian emergencies. Looking at the patterns of gender-based violence among adolescents in humanitarian settings, this information from Gage longitudinal study following 20,000 young people in Africa, Middle East, and South Asia revealed some interesting findings among adolescents in Lebanon, Jordan, and Palestine. For example, in Jordan, we see that girls are less likely to experience violence, but more likely to talk to someone about it compared to boys. And this is a very interesting finding when we think about the nature of gender-based violence. Sometimes it's more difficult for men and boys who are exposed to a form of gender-based violence to disclose the violence, because the stigma can be even higher among for men and boys who are subjected to violence, to gender-based violence, usually sexual violence, than for girls. In Lebanon, we see that violence pervades Palestinian households in Lebanon's Ain el-Hilwa and VAWG camps. Also, the gender stereotypes make that boys see themselves as protectors, so they have to protect the girls, but at the same time, girls' accounts indicate that their brothers are the perpetrator of extreme violence. So it's very tricky, this relation between the role of men and boys seeing themselves as protector of the women and girls within their community, but at the same time being the perpetrators because they replicate patterns of violence, of gender-based violence that they have learned. So, for example, here we have one testimony of a girl from the study saying that my brother heard the first false rumor that I was talking to a boy in the street. He came home and started beating me so hard and imprisoned me at home. He kept beating me several times and no one defended me, not even my close sister. After several times of being hospitalized, my uncle took me to live with him. So we see as violence is a cycle and it's a learned behavior. As COVID-19 entered our lives, it had a very severe impact also in the increased risk of gender-based violence and domestic violence. The pandemic, we can say, has amplified household stress and intra-household violence. From this slide, we can see that the orange line indicates parents yelling at adolescents has increased, and parent hitting at adolescent has increased. And we see that the yelling is more prevalent than the hitting because of the mental stress under which families were put, which reflected in violent reactions, including yelling inside their household. Gender-based violence has been named the shadow pandemic during COVID-19, which means that never before we understood how much health emergencies, humanitarian emergencies impact severely women and girls, and they increase the risk of gender-based violence. For COVID-19 particularly, the quarantine paradox, which refers to the idea that while quarantine is necessary to save life, it can also cause serious psychological consequences and a surge in domestic violence. So especially in the first wave of the pandemic, we saw that the measures to control the spread of the pandemic, such as the lockdown, the mobility restrictions, has caused that survivors were obliged to live in the same house of the perpetrators and were not able to leave the house. So this, and also being locked in the house, increased stress within the household, so increased the risk of gender-based violence, both from a perpetrator perspective and from a survivor's perspective. At the same time, women survivors and girls survivors of gender-based violence has less chance to seek for help because the health system was overwhelmed with the response to the COVID-19 pandemic, and many other services such as protection or legal services were disrupted due to the pandemic, causing women and girls to not be able to seek for support and for life-saving services and for shelters. For example, in Lebanon, there are reports of forensic doctors being unable or unwilling to document physical and sexual abuse of survivors at police stations for fear of COVID-19 spread, while law enforcement work was diverted into other priorities. Since the beginning of the pandemic, women's organizations started receiving a lot of calls from survivors in China, in Europe, but also in our region. For example, in Tunisia, a 400% increase in reports of hotlines was documented. And in the overall region, it was reported an increase between 50 and 60% of requests of help from survivors to women's organizations. So after these excursus on the risk factors that may determine an increase in gender-based violence against women and girls, we may ask ourselves what we can do, especially in our region, considering the many challenges and the many barriers. There are definitely many successful experiences and good practices that we can take into consideration and we can get inspiration from. One of them is the Violence Against Women awareness campaign in Afghanistan, implemented between 2016 and early 2017 by the Public Legal Awareness Unit of the Afghan Ministry of Justice at that time, and 2 NGOs, with the support from the International Development Law Organization. The campaign was rolled out across 9 provinces, including some that pose significant security challenges, and this campaign was able to reach 5,000 people. The aim of the campaign was to educate participants on all forms of gender-based violence, including domestic violence, forced and underage marriage, rape, forced prostitution, beating, harassment, and humiliation. As we said before, it is important to know what is the shape of gender-based violence and the different form of gender-based violence to be able to recognize it, prevent it, and respond to it. The Violence Against Women awareness campaign in Afghanistan included many initiatives at a different level. For example, signing a symbolic pledge banner where students affirmed their commitment to say no to violence against women. It is very important that this is visible to everybody. So this symbolic pledge was a very important action taken by the students, including male students, as we can see from the picture. Also, public awareness, citizens' rights was an important part of the initiative. Schools were also involved, with high school teachers that were empowered to raise awareness locally within their schools. Also, the local ownership was helped to ensure the sustainability and success of the campaign in terms of participation of the local community, not only in the implementation of the activity, but also in the design of the activities themselves, so that they are acceptable by the local community and accepted by the local community. Live drama performances, which engage the young audience on an emotional level. Sometimes these kind of initiatives are much more powerful than theoretic explanations. And very important, the involvement of community leaders who were familiarized with constitutional and religious legal frameworks to ensure their decisions are fair and consider the rights of all parties. And even in time of COVID-19, we have many good practices from the region, especially during the first wave of COVID, where, as we say, the lockdown obliged people to stay at home and many services to temporarily close. Countries identified new methodology to support survivors, also making use of technologies. For example, from this UN Women report on the impact of COVID-19 on violence against women and girls, we see that in Morocco, a national platform was operated by the National Union of Moroccan Women to file online complaints through a mobile application. In case of danger, the platform is in direct contact with the National Security, the Royal Guard, and the Public Prosecutor's Office to report cases and enable rapid intervention, as the survivor can be geolocated through the app. Furthermore, the Regional Council of the College of Physicians and the Moroccan Society of Psychiatry is also providing psychosocial support remotely. So wherever it was possible to have an internet connection, but also phone calls with survivor, alternative methodology from the face-to-face were implemented. The same in Lebanon, where judges convene virtual sessions to issue protection orders from women at risk of and surviving violence. It was also important at the beginning of COVID to have a very strong communication also perspective. And so communication activities were being carried out in communities to raise awareness on the possible impact of the COVID-19 measures on violence against women. Therefore, many activities mainstreamed the violence against related to COVID-19 and health, mainstream the violence against women and girls component. Additionally, information on available services are disseminated via radio, television, and social media channels in different local languages, as seen in Egypt, Iraq, Morocco, and Palestine. At the beginning of this session, we say that the health services constitute, especially during emergencies, including health emergencies, sometimes the only point of contact for survivors to seek for help and services. To measure that, the health cluster coordination conducted different surveys between April and May 2020 to measure the health services utilization by GBV survivors during COVID-19, and these surveys were conducted in Afghanistan, Iraq, and Somalia. The results showed a 45% increase, not only in GBV, but also in the request of survivors for health services. The survey's finding highlighted an increase not only in domestic violence, but also in sexual violence against girls, along with concerning upsurge in female genital mutilation, and this particularly in Somalia. And we know that when there are emergencies, disruption of services, there is the risk not only of an increase of existing forms of violence, but also of the creation of new forms of violence. Initiative has been undertaken at the country level to address the continuity of life-saving services and to establish referral linkages, to update also the referral linkages in order to connect survivors and reach out to women and girls in need of support, both with face-to-face services, but also with remote and online services. And we have many good examples in the region. For example, in Afghanistan, a guidance note was developed for women's protection centers operating during the COVID-19 pandemic in partnership with UN Women, because of course, the shelters had to face the double pandemic, the increase of GBV survivors who were in need for shelter, but also the cases of COVID within the shelter. So how to manage these two pandemics. Management support was provided as needed. In Iraq and Lebanon, guidance was produced for both remote and face-to-face health services for women who may have been subjected to violence. So to teach doctors and health providers how to provide support remotely. Online training was conducted on GBV and COVID-19 for frontline workers from the Ministry of Interiors and Ministry of Defense, because in Iraq, for example, during the first lockdown, staff from Ministry of Interiors and Ministry of Defense were the only allowed to circulate during the curfews and lockdown. Additionally, remote case management was put in place with the aim of establishing safe, strong, and flexible communication in line with survivors living in confinement with their aggressors. The pandemic also pushed to find new solutions rapidly. So, for example, in Pakistan, GBV specialized telemedicine support and health services were implemented in collaboration with the Institute of Psychiatry in Balochistan. And the case study from Pakistan is really a good practice. And we hope that this can inspire other countries to do the same. Additionally, the capacity of health providers in the country's high-risk burden provinces was built to support them to integrate GBV response into their services during the COVID-19 pandemic. So what are the key messages and the key takeaways that we can take from this presentation and the information we have learned during this session? One is that gender-based violence, and specifically gender-based violence perpetrated against women and girls, is largely driven by deep-rooted gender discrimination. So it cannot be addressed if the gender-based discriminations are not addressed at the different level of the society. And gender-based violence is a significant threat to adolescents' health and well-being in the region. At the same time, we know and we have learned that health services are critical for mitigating the health impacts of violence, whether physical impacts or mental health impacts or sexual and reproductive health impact. For example, prevention of HIV, unwanted pregnancies, and STIs in case of sexual violence, and adverse medical health outcomes that can result from a traumatic sexual experience of sexual violence, but also from a long-standing situation and exposure to domestic violence. At the same time, we know that health services for women and girl survivors remain adequate in many countries of our region, and these has a severe consequences for the health of women and girls. And this means that we have to run throughout the region quality assessment to identify the gaps and to address those gaps whenever it's possible, whether at the facility level, the capacity building level, the equipment level, to make sure that GBV survivors can receive appropriate, compassionate, and safe health care. WHO recognized all of that and is intensifying efforts to ensure that violence against women and girls is better prioritized and is institutionalized within the health sectors in emergencies, and that health partners are equipped with the technical knowledge they need to respond. And the technical resources, the human resources, the financial resources are very much needed to bring forward these very important tasks. And so WHO encouraged donors, UN agencies, and NGOs to step up efforts to integrate services for women and girls survivors as a core part of the health response in emergencies, including for COVID-19. We don't have to necessarily have vertical services. We can and we have to integrate the GBV response within the most important health services for women, such as reproductive health, mental health, family planning, and emergency health. Thank you so much for your attention, and see you soon.